Welcome back to Back in Motion Health Talk. I'm Dr. Justin Walbum. Today, I want to talk about statins. This isn't going to be a discussion about whether statins are good or bad. Medicine is rarely that simple. Statins have undoubtedly changed the treatment of cardiovascular disease. For the right patients, they've reduced heart attacks, strokes, and cardiovascular deaths. That's one of the reasons they're among the most commonly prescribed medications in the world. But as our understanding of cardiovascular disease has evolved, so has our understanding of cholesterol, cardiovascular risk, and the effects of statins on the rest of the body. And I think that that's a conversation worth having. So let's begin with cholesterol itself. For years, we've been taught to think of cholesterol as something that we should lower at all costs. We have good cholesterol, bad cholesterol. But cholesterol isn't the enemy. Your body really couldn't survive without it. Every cell membrane contains cholesterol. It's used to make steroid hormones like testosterone, estrogen, cortisol, and progesterone. It's essential for vitamin D production, nerve tissue, brain function, and digestion. So the problem isn't cholesterol itself. The problem is that when cholesterol is carried into the walls of arteries by particles that contribute to plaque formation. And that's why many cardiologists and lipid specialists are beginning to look beyond traditional cholesterol panels. You may have heard of LDL and HDL cholesterol. Those measures are still useful, but they're no longer really the story that we should focus on. Today, there's a growing interest in apolipoprotein B, or ApoB for short. Every particle capable of contributing to plaque carries exactly one ApoB molecule. And that means ApoB tells us how many potentially plaque-forming particles are circulating through the bloodstream. Now think of LDL as measuring how much cargo is being transported. Think of ApoB as counting the number of trucks that carry that cargo. So many experts believe that particle number is a better predictor of cardiovascular risk than cholesterol concentration alone. So another marker that deserves much more public attention than it's getting is lipoprotein A, or LPA for short. Now, LPA is largely an inherited trait. Diet doesn't really have a lot of influence on it, and exercise changes it very little. Someone can have an excellent cholesterol panel and still carry an elevated cardiovascular risk because of a high lipoprotein A. If heart disease runs in your family, especially at a young age, it's worth asking your physician whether you've ever had LPA measured. Now, a third marker is apolipoprotein AI, or ApoA for short. Now, ApoA is associated with HDL particles and reflects one's body's mechanism for transporting cholesterol away from the artery walls. So looking at ApoB, ApoA, and LPA together often provides much more complete picture than simply asking whether your LDL is above or below a certain number. So where do statins fit into all of this? Well, statins reduce cardiovascular risk primarily by lowering the number of ApoB containing particles in circulation. They accomplish this by inhibiting an enzyme called HMG-CoA reductase. That enzyme is part of something called the mevalonate pathway. And most people have never heard of the mevalonate pathway, but it's one of the body's major manufacturing systems. It produces cholesterol, but cholesterol isn't the only thing it produces. The same pathway also produces compounds involved in cellular energy production, mitochondrial function, protein signaling, and normal skeletal muscle physiology. Statin is prescribed, we're intentionally trying to modify a metabolic pathway that affects more than cholesterol. So we shouldn't be surprised when other tissues respond to that change. Now you might be asking, why is a chiropractor talking to me about cholesterol? And the answer is that I don't spend my day treating cholesterol. I spend my day treating people who hurt. Patients come into my office because they have back pain, hip pain, shoulder pain, leg weakness, difficulty climbing stairs, muscles that fatigue too quickly, aching that doesn't seem to have a clear explanation. So as a musculoskeletal physician, I naturally think about discs, joints, tendons, arthritis, spinal stenosis, nerve compression, and biomechanics. And those are all very appropriate things to consider. But I also think that we should be asking another question, and that is, could a medication be contributing? One of the best recognized effects of statins outside of cholesterol lowering is its effect on skeletal muscle. So when people hear the term statin myopathy, they often picture severe muscle pain. But side effects can be a lot more nuanced than just the most extreme side effect. Patients don't always describe pain. Sometimes they describe weakness, sometimes reduced endurance. Sometimes they say their muscles feel tighter than they used to. Sometimes they tell me they simply don't recover from activity the way they once did. Walking uphill has become difficult. Climbing stairs has become harder. Standing from a chair takes a lot more effort. Their functional capacity slowly declines. Now, those changes may develop so gradually that they're blamed on aging, arthritis, or simply getting out of shape. Now, whether those symptoms are caused by the statin, another condition, or a combination of factors depends on the individual patient and requires careful evaluation. But I think it does deserve to be considered. One question I've wondered about throughout my career is this: how many patients have undergone orthopedic evaluations, MRIs, injections, or even surgery because medication effects were never included in the differential diagnosis? I don't know the answer to that, and I don't think anyone does. But I believe that it's an important question. Another topic that's frequently discussed is coenzyme Q10, or CoQ10 for short. Because statins inhibit the mevalonate pathway, they also reduce the body's natural production of CoQ10. Now, CoQ10 plays a really important role in mitochondrial energy production, particularly in tissues with high energy demands like skeletal muscle and the heart. Because statins interfere with this important protective coenzyme, I believe that most, if not all, people taking statins should consider supplementing with CoQ10. But understanding why researchers became interested in CoQ10 helps illustrate that statins affect more than cholesterol metabolism alone. So what's the takeaway? Well, statins remain an important tool in cardiovascular medicine for sure. For many patients, they're absolutely the right choice. But at the same time, medicine continues to evolve, and we may consider that statins may not be appropriate for as many people as are taking them currently. We're learning more about ApoB, we're learning more about lipoprotein A, and we are recognizing that cardiovascular risk is more individualized than we appreciated, say, 20 years ago. And we're continuing to improve our understanding of how medications influence the entire body, not just the disease they're intended to treat. My hope is that patients become more informed, know your numbers, ask questions, understand why you're taking the medication, know what benefit you're expecting to receive, and try to understand the possible risks and side effects of those medications. If something about your body changes after starting that medication, don't ignore it. Don't assume it's aging, and don't assume it's just your back. Also, if you have a new symptom that shows up without explanation, it could be your medication, even if you've been taking that medication for a very long period of time. Bring it up with your physician. Good medicine isn't about treating a laboratory value, it's about treating the whole person. I'm Dr. Justin Walbum from Back in Motion Disc and Joint. Thanks for listening, and I'll see you next time on Back in Motion Health Talk.